Welcome to Cracking Cancer, where we tackle the tough questions about cancer with real patients and world experts. Our mission is to empower the cancer community through education, bring transparency to the oncology system, and drive funding for critical cancer research. Whether you're facing a diagnosis, supporting a loved one, or simply here to learn, we're here to bring clarity, hope, and action to the fight against cancer. Hey everyone, welcome to Cracking Cancer. I am your host, Dr. Kyle Concannon. I'm a physician scientist at the University of Colorado, and today we are talking about small cell cancers. And joining us, we have Matthew Baker and Misty Shields. And maybe you both could take a second and introduce yourselves.
So I'm Matthew Baker. I was diagnosed with small cell lung cancer back in September. I started treatment in the week of Thanksgiving, and I am currently in active treatment.
Well, thank you for joining us. Misty.
Hi, happy to be here. Misty Shields. I'm a thoracic medical oncologist and physician scientist, currently at Indiana University School of Medicine and Indiana University Health Physicians. I have a research lab and a personal passion and connection to small cell lung cancer. Looking forward to our discussion today.
No, thank you both for being here. And without further ado, we'll get right into it. Matt, I know you mentioned we're diagnosed with small cell lung cancer and you're on active treatment. So I'd like to dive in a little bit. My first question to you is, what was it like being diagnosed with small cell lung cancer? Maybe you could walk us through that a little bit.
Yeah, absolutely. So honestly, it was not something I ever expected. Never smoked in my life. Really, lung cancer definitely wasn't on my radar. I have a family history of cancer, but lung cancer wasn't it. And then when I got the diagnosis of small cell, and just all it takes is one Google search and you realize, holy crap, this is something serious to think about. And really, it was just scary. It was an unexpected find. I feel lucky in that way, but it was definitely a devastating diagnosis.
What symptoms were you having? What led to the diagnosis?
Yeah, so I went to the hospital with a low heart rate. And they gave me some medicine, did a full cardiac workup, sent me home. This medicine raised my blood pressure. So when I did a follow-up visit, my blood pressure was like 240 over 130, and they're like, go to the ER. So I went to the ER. They did a CT, or my D-dimer was elevated, so they did a CT scan. And really, I have to thank a pretty aggressive pulmonologist that said, hey, radiology says it looks good, nothing to worry about, old infection, don't worry about it. He said, but it's just a little bit bigger and the shape is a little concerning. Do you want to do a PET scan or a bronchoscopy? I said, well, if I do the PET scan, am I still going to have to do the bronchoscopy? And he said, maybe. I said, well, let's just start with the bronchoscopy. So that's how I was diagnosed.
Wow. That is not the common story, I'll say, but everyone has their own unique story. And you had mentioned when you were diagnosed, you did some Googling. What did you see?
Really, at the time, I just seen the first thing that pops out to you is the survival rate with limited stage small cell lung cancer, even with treatment. It doesn't look promising on a Google search. So then, you start going out and realizing Google's only so much information. And I start putting together medical journals, and I'm not understanding the language. It was kind of confusing because there wasn't really a lot of treatment things I was seeing compared to other things I know and have had knowledge of in the past. So it was really just like smack you in the face, like, oh my gosh, am I going to survive this even with treatment? And what does it look like moving forward?
Wow. Well, and I think a lot of people who are newly diagnosed with any type of lung cancer, any type of cancer, if they're looking into details about their disease, they have a lot of those same feelings. So I'm really happy to have Dr. Shields here, Misty, to talk with us about the details of small cell cancer, small cell lung cancer in particular here, because Misty, you've dedicated really your professional career to the study of this. So we're really lucky to have you on. And you're also a lovely human because I've hung out with you and met you in person. So really thrilled to have this opportunity. So maybe we can start off by answering the question of what is small cell cancer and small cell lung cancer?
Thank you, Dr. Concannon, for having me on. And thank you, Matt, for sharing your story. I will agree that Dr. Google has a terrible bedside manner, and we can all be better than Dr. Google, is my hope. And so, small cell lung cancer is a type of of lung cancer that's known for its neuroendocrine features, meaning it has this primitive biology that is able to use certain hormones and pathways to leverage it to grow, to spread, or to avoid chemotherapy or immunotherapy. And so, historically, small cell lung cancer is the most common form of small cell, but there can be small cell of other cancers, which is known as extrapulmonary small cell, meaning it's small cell that occurred outside of the lung in another organ, like the bladder or the pancreas or the prostate. And typically treatment for those are all extrapolated based on small cell lung cancer being the most common form. And when we think about small cell lung cancer, we're thinking about treatment by stage, which is, as mentioned by Matt, limited stage or extensive stage based on this historic VA system that was established in 1957. Can the area of cancer be contained by a radiation field or not? If it is, it's limited to the field. And if not, it's extending outside of the field.
Yeah, that's a great overview. And Matt, you said you were diagnosed limited stage. So they felt that this could be contained within a radiation field. Was that right?
Yeah. So, and that's even a little conflicting in my story is my pathology came back extensive stage. But when I had the PET scan afterwards, that extensive area didn't show up. So they said, oh, this is limited stage.
I see. Yeah, I think there's a lot to be confused about with small cell lung cancer, and hopefully we can work together to make some sense of it. Well, you were diagnosed at limited stage, and then you underwent a treatment plan. What was the treatment plan that they designed for you, and how's it going?
So they went with 6 rounds of carbo and etoposide at 5 AUC. And then 33 rounds of radiation therapy. And probably two rounds in, they lowered it to 4 AUC, and I did finish all 33. I'm in between my 5th and 6th round right now. And really, I'm going to tell you, it's been quite the challenge. I've ended up in the hospital 3 times through this treatment. I've had ototoxicity to the carboplatin. So I've completely lost all of my hearing, which has been a challenge for sure. And the exhaustion and all of that, it's been crazy. And really trying to navigate through this on some days when I feel like I'm trying to navigate it on my own and figure out what the next steps are and kind of trying to stay ahead of it the best I can.
Yeah, and I know we're getting into the extensive stage stuff here in a little bit, but the backbone of treatment for small cell aggressive cancers is chemotherapy, and the chemotherapy that you got is a pretty common one used. Maybe tell us a little bit about what the experience was like, even just receiving chemotherapy in the infusion setting. I think a lot of folks listening may be newly diagnosed with small cell cancer, and this whole world is new to them. So what was it like having your first dose of chemo? What did you experience then, and how did that change over time?
Honestly, my first dose of chemo, I wasn't as afraid of as I was radiation. I never met anybody that ever had radiation before, and it scared the crap out of me. Like I was warned, hey, you might have trouble swallowing and all this type of stuff. And I was afraid of it. Chemotherapy on day 1 is my longest day. I'm usually there 5 hours. With all the medicine they pump you with, I'm exhausted. That hasn't really changed. It's actually probably gotten worse. As it builds up in your system, it makes you more tired. But my infusion center, I have to say, is really pretty great. I've learned to, cuddle up in the chair and fall asleep the best I can. And pretty much just stay hydrated. And if I feel a little hungry, eat something to help with the nausea. Yeah, I was more emotional with radiation. Even when I finished at 33, I rang that radiation bell and I went out of the door and I just cried. And I was like, I never really told anybody how like every day going and doing that was so emotionally taxing. It didn't hurt. And like there was no pain to it. It was easy peasy, but it was just the emotional portion of it. And then when I was hospitalized, the way the hospital is that I go to is across the street from the cancer center. So they had to load me up in an ambulance to take me literally through the parking lot because there was no covered walkway, which was just even more emotionally taxing to go through that. while you're already in the hospital setting to get it done was pretty crazy.
Wow. And I want to hear more about the radiation, but since we're chatting about the chemotherapy, Misty, maybe you can explain a little bit, why do we use chemotherapy for small cell, and what kind of symptoms might someone experience when they're receiving chemotherapy?
That's a great question. And Matt, thank you for sharing your story and all of the journey that you've faced so far to date. You know, we as oncologists are on the other side of it and don't hear and see all of the, you know, the challenges our patients may be facing. And thank you for sharing that so that we can help, you know, serve you better and support you better. And, you know, so with chemotherapy, these, as mentioned, are typically these cytotoxic chemotherapies, typically cisplatin or carboplatin, a platinum-based therapy, and etoposide, a topoisomerase inhibitor. This has been the standard really since 1985, when this combination beat out another multi-drug regimen called CAV, or cyclophosphamide, adriamycin, and vincristine. It was an effective regimen, but very toxic. And this carboplatin or cisplatin and etoposide regimen was just as effective, really becoming the new standard of care for really 4 decades. And so with that, the reason why this is so effective is, as we know, with these neuroendocrine malignancies like small cell, they're growing quickly. They're addicted to growing quickly, and they have aberrant DNA damage and repair enzymes. And so when you damage the DNA with chemotherapies like platinum and etoposide, the cancer is growing so quickly it cannot repair, and it's catastrophic in terms of the small cells growth, and does cause these small cells to die, which is what we want. And so very effective for patients, high response rates, works quickly. And sometimes we see patients who might be in the hospital, even on a ventilator in the ICU when they're diagnosed. If they came in with symptoms like respiratory distress or respiratory failure, and we start chemotherapy after a diagnosis of small cell, and patients may get out of the ICU, be off of oxygen, and walk home feeling so much better, which is so fortunate for our patients to really feel better. Where we run into a little bit of trouble is that small cell is a smart cancer. And so it, to escape the role of chemotherapy, may cause additional damage and changes in its own biology using something called MYC or MYC paralogs, c-MYC, n-MYC, l-MYC, and using those extra copies, which are made outside of the DNA and extra chromosomal copies, to use that to escape. And that's what we call chemo resistance. And that's where, you know, historically for small cell lung cancer, we have had an absence of progress for many years up until just the last 5. And really, we're seeing all these exciting breakthroughs and new drugs for patients who are impacted by small cell. So, you know, really, small cell is chemosensitive. It's radiosensitive, meaning radiation sensitive. So using chemo and radiation is really the way to go. You're synergizing your method of attack to really drill down on this cancer, and we're shooting for cure.
Thanks so much for explaining that. A wonderful explanation for the underlying biology, why we're still using these primitive tools of chemo that are really, really effective here. You know, I've had a recent conversation with patients that asked me, I thought these chemos came out a while ago. Why are you still using this? Am I actually getting, you know, the best treatment? And the reality is these classics are classics for a reason. They're still some of the best therapies we have in cancer. And this is a great example of where they can be used really effectively, sometimes in combination with radiation. And Matt, I'd love to hear more about not only the process of what you went through getting radiation therapy, like what does it look like? You know, what do you have to do in order to receive the radiation physically? And then the toll it took on you. You know, this was not an easy course for you. And you mentioned hospitalizations, emotional toll, logistical challenges. This is not an easy walk. So yeah, I'd love to start off by hearing, what was the process like receiving radiation to the lungs?
Yeah, so the first step for me was I met with the radiation oncologist, and then we set up the simulation, which is pretty much where they map you out on where the beam is going to strike you, I guess is what a good word to say. And then a couple weeks, maybe a week or two after that, in between my first and second cycle, I started radiation. And it was just, pretty much go in, take off my shirt, lay on the table, and pretty easy peasy. Probably once the machine started to do its thing, I was probably 2 minutes tops, 15 minutes total, just every day for the 33 days, Monday through Friday. And then if you get pushed or whatever, a couple extra days will add on. But I finished those 33 rounds. I think one of the best things for me is the staff at the radiation center I went to was great. I'd go pick up my wallet and I might have a note or a picture of them being silly. One day I walked in and the tech jumped out of the closet trying to scare me, but it just made it a fun place to go for those very short minutes every day, to kind of like just make you feel better about being there, which was definitely helpful for me, because I really radiate off of people's bouncy energies, which would give me a little bit of extra boost. Like, okay, I'm going to go do this today. And, I hope that favorite tech is there because they're going to make the day better, because it was emotionally taxing. And you feel vulnerable for that little bit of time. So when that day was over, I was very grateful, for sure.
Wow. Yeah, thanks for sharing that. And I really appreciate you mentioning how the individuals who were involved in your care, who were not the physicians necessarily dictating we're going to do this or that, how much they influence the experience of going through it. I think a lot of times we, either as providers or those who are trying to support someone, we struggle to know the best way to help. And we have this phrasing in oncology where we want the highest quality of life for the longest duration of time. But quality is, we struggle to measure that. There's no laboratory test for your quality of life, but it's the day-to-day interactions that you're describing, So I think it's helpful to hear for us, for those listening, that those are the difference makers between what makes this course bearable, sometimes even pleasant, when otherwise it's really hard.
Mm-hmm.
So tell me, the symptoms over time, you mentioned didn't burn, didn't hurt.
Mm-hmm.
How did things change over time?
Yeah, so probably towards my last, I would say 10 days, I did start having to use the magic mouthwash to be able to swallow without really any pain. And then kind of doing chemotherapy and radiation at the same time. Like I knew chemo wasn't causing me having trouble swallowing, whereas chemo was causing me diarrhea. Like, those different symptoms, but really just tired. Like, for example, the first day I had radiation and chemo on the same day, I was like, I can drive myself. No big thing. I'm only 8 miles from the infusion center. I slept the entire time in the chair, and then I went out to the parking lot, turned the car on, and fell asleep for 2.5 hours before I drove home. And from there on, I know day one, I can never drive myself. It's just not possible. I'm just exhausted. And now it's pretty much, even on the second and third day of this, the Atopo side, I'm usually getting a ride at this point just because I don't know how tired I'm going to be at the end of it.
Wow. And Misty, does this side effect profile sound consistent? What other things should people look out for?
This is an important point, that patients who are undergoing chemotherapy, we always want them to have a care partner, someone, a friend, a loved one to be there, because sometimes the pre-medications we give can make patients more drowsy. And so it's important to have support just so that you can take a nap, you can kind of let your hair down and really be able to know that someone else is there helping and supporting you, even just to get you safely home. And so, Matt, I'm glad that you have now support for you to make sure that you can get all your treatments and not have to take naps along the way.
Well, at first, I had that fear of like, don't come in with me because I don't want to sleep while I sit in this semi-comfortable chair and you're in this uncomfortable chair. So I was like, I'll just do it myself. And I moved from, we'll just wait in the car. I'm not going to make you come here and watch me sleep. I'll feel bad sleeping or I won't sleep knowing you're there. But now it's just like, come on in, I'm sleeping, and everybody's okay with it.
Very good. The typical side effects that we anticipate from chemotherapy when I'm chatting with my patients and introducing the role of these agents in the care for patients with small cell, we always think about fatigue, right? And fatigue may be different for each patient. It may mean that you have to take a nap. It may mean that you're still able to care for yourself. And sometimes it may mean that you need additional support. And so fatigue can look very different for each patient, depending on kind of your level of function before and what you've got on your plate as you're going through this. Are you caring for another loved one or a family member? We always think about other side effects such as low blood counts, which can compound the fatigue, things like low red cells, white cells, platelets, and bacteria-fighting cells called neutrophils. Those can be important because that might put you at risk for an infection if they get too critically low. Those are a kind of natural barrier to protect ourselves from infection. Another side effect that we're thinking about with this regimen is hair thinning or hair loss. It is fairly common with etoposide and this regimen, and so making sure patients know that and are not shocked if that happens, so that they know that they have support. And if they want to get a fun, curly, pink-haired wig during treatment, this is the time to do it. I usually tell patients. And other things we're thinking about are watching, again, as mentioned, the ototoxicity or hearing, making sure that we're doing hearing tests along the way to make sure that hearing loss is not occurring. Also watching the kidneys, liver, and other blood counts, such as electrolytes, such as magnesium or sodium, to make sure that they're not being affected by the treatment.
That's great. Matt, do those other side effects resonate with you?
Yeah, I'm gonna mention this, especially for anybody that's just been newly diagnosed. As a man, when it came to hair loss, I thought no big deal. I've had moments in my life where I shaved my head anyhow, but when you grab that first handful of hair, it's reality slaps you in the face. It makes it real. Not only to yourself, but when you walk out the door, like my hair's, I could see it growing here a little bit, but I'm a couple weeks out between treatments, so it started to pop back in there for me. But it was actually harder than what I thought it was going to be, because now not only was I a cancer patient, but to the outside world, I look like a cancer patient, and in the mirror, I look like a cancer patient, which was really traumatic that I wasn't expecting it to be. The low blood levels, yeah, I've been living with that since after the first round. It's been my first 2 visits to the hospital was pretty much because I had a fever. And then the last one was actually my pulse ox was going low, and they told me I had pneumonia. But every single time I've been back in there, I've been dealing with the neutropenia, fevers, and all of that wonderful stuff that I really wasn't expecting to happen. And then obviously the hearing loss, to wake up back in January, just, it really pretty much after my second round, and not hearing right, like all of a sudden I can't hear the TV. And then, end up going to the audiologist and them pretty much saying, oh, we don't think this is going to be reversible. And right now I'm actually waiting for cochlear implants. I just have to finish. I've been too neutropenic, so they're waiting for me to finish chemo to get that all scheduled. Because right now I'm not hearing anything, which is another one of those you don't know how to. Your life functions differently, and it's all because of cancer. And you don't think, oh, I have lung cancer, I'm going to lose my hearing. Like that's not something that was ever on my board. But it's been pretty traumatic, really for me and everybody else around me. I'm actually heading off to Colorado in the summer to learn sign language because I don't have a way to communicate with anybody unless I have my phone and my stuff that's captioning everything everybody's saying. So it's just been a challenge that nobody warned me of that side effect ahead of time. Wasn't something I was expecting by any means.
No, that's a dramatic sacrifice. And I think there are certain levels of suffering that we can imagine ahead of time and emotionally prepare for. But what you're describing is a a type of suffering that you weren't prepared for. And it's hard to know how that's going to hit you. And I think it's hard for your loved ones to know how to help you. So maybe getting into that a little bit, you had this daily routine, specifically mentioning with the radiation and the fatigue and these things that are somewhat cumulative, meaning they get worse over time. What do you think was the most help for you as you were going through it from someone else? And what would you recommend caretakers consider?
Understanding, like having that ability to understand and really listen, because they can never, no matter how much I tell somebody, this is how I'm feeling. But also on the note that, at least from my circumstances, I keep a lot of how I'm feeling bundled up. Almost that fear of being the burden or worrying my loved ones. So if I'm feeling extra sick, I might not say anything, just because I don't want to worry anybody, because I worry more when they're worrying. But really just, look for the signs that we're not telling you. If you know I haven't eaten yet today, don't ask me if I'm hungry. I'm probably going to tell you no. But if you bring me a bowl of soup, I'm going to eat it just because you made it. Even if I don't even want it, I'm going to still eat it because you made it, which I do need it. So that would be my advice to caretakers: is just don't always look at us at face value. There's a lot more going on deep inside that we're not sharing. At least that was the case for me. And trying to really break away from that. Like when I was first diagnosed, I didn't have my fiance come in with me. It's like, I want to be in control of the situation. Whatever the doctor tells me, I want to process it myself and then relay it to you later, which I'm kind of realizing really wasn't the best, because it was, leaving that person on the outside as well. But it didn't allow them to completely, fully understand everything that was going on at the same time.
I'm happy you shared that. This has been a theme that's come up on this podcast quite a bit. JJ Singleton speaks to it a lot. He's an individual with metastatic colon cancer. And then we had Captain Bill Phillips, who's a fighter pilot, who also is diagnosed with cancer. And both of them have, in their respective episodes, had articulated this feeling of not wanting to be a burden on other people. And that feeling of wanting to support those around you by really removing this burden from them, that's a tough dynamic for people, and giving other people the opportunity to help you because they're going to enjoy doing that. That's going to be really meaningful for them. It's a really hard thing for many people to do. And I'm not saying I would be any better at it. It's a common feeling that we feel to not want to be a burden on other folks.
Yeah. And it actually took a 80-some-year-old man with stage 4 non-small cell lung cancer that I met. And I was telling him, oh, yeah, I don't really have anybody go in with me. And he was like, no, absolutely not. You need to. And I thought, kind of made me sit back and say, okay, I'm going to listen to this man of many wisdoms, for sure.
Well, and that's a great transition point. Misty, you're involved with many of the patient advocacy organizations. And I always try to link up my folks, my patients, with patient advocacy organizations. Are there any that might be particularly helpful for someone who's newly diagnosed with small cell? Where should they turn to?
Thanks, Kyle. Of course, I'm a little biased with the small cell smashers that I helped to create in 2023. I know Matt is.
Thought you might be.
Yeah, Matt is also a fellow smasher. And we have a lovely community of over 1,500 patients and their care partners all over the world. And so, I think no one should fight this disease alone. And you find your tribe, whether it's people that you know in your community, your neighbors, your friends, your loved ones, or online. And I think that having a community of people who have gone through this, who are going through this, is the best way to support you, to know these unique changes, or to give you kind of a heads up along the way. Hey, make sure you ask your team about this, or what have you thought about that? What about the new treatment? What about the plan A, B, and C? And so I think it's really important to have a community, to know that you're not alone, and to have people lift you up, on those bad days, when you're going up a mountain, when you're stuck in a valley on the other side, trying to get out, to have your friends, family, loved ones, and to me, fellow smashers. I think is important. But there are a number of wonderful communities. Ours is affiliated with Longevity, but there also is a group with Live Lung, a small cell community, as well as Go2 Foundation, and many other foundations that are helping to support our patients and their loved ones impacted by small cell. So if you don't have a community, please find one. We don't want you to fight this alone.
Well, and even beyond emotional support, which, thanks so much, Misty, for relaying those and all your work and facilitating creating that community, which is huge. Many people are diagnosed and treated in community settings where that oncologist may see a lot of different things. And something like small cell lung cancer may not be much of their practice. So when you are talking with, say, the smashers, they know more about small cell than most medical oncologists do collectively. So if you're questioning, is my treatment, the best treatment? I'm having this symptom. I've heard about this therapy. Talking with these groups gives you really, I think, cutting edge level knowledge at your fingertips from people who have walked the walk. So I think not only is it a place for support, which is really important, but also to make sure that you're most comfortable with the treatment path you're going down. That's one thing I've mentioned to my patients who have other rare kinds of types of treatments is, hey, if you hear something in this patient advocacy organization that you think we should be considering, I want to know about it. Because a lot of times they'll hear about something that may be cutting edge. It's at an institution that, is not ours, but we want to make sure everyone's getting the best care they can. So Misty, I guess it's a shout out and a thank you to setting that up and offering a publicly accessible resource for everyone like Matt.
Yeah, it's the least we can do, and to create a community that's safe, kind, and much better than Dr. Google and much more updated. But we can make sure that patients think about all aspects of their care. They have all the information armed and ready to make sure they get the highest level of care, no matter where they are across the world.
Yeah. Well, and, Matt, you had mentioned in the beginning here, diagnosed with limited stage small cell. And I want to get a little bit into now extensive stage. But Misty, maybe you can start and kick us off by saying, what are the general treatment paradigms between limited stage and extensive stage? Maybe not going into nitty-gritty details, but do we approach them differently?
Yes, the treatment for extensive stage is slightly different. And so we want to really drill down on the therapies that are in the bloodstream that can go all over the body to the areas we can see and not see on scans. And so for that reason, we really focus on treatments that are what we call systemic therapies or IV therapies. And that really would be that combination of carboplatin and etoposide. And in 2018 and 2019, we saw 2 phase 3 studies that read out and then were approved the next year later, respectively, with atezolizumab and durvalumab. And in those studies, using immunotherapy or anti-PD-L1 therapy to help use the immune system to see and fight the cancer. So that is typically what we consider the first line of standard of care. There's been a recent advancement of adding an additional drug called lurbinectedin, which is another type of chemotherapy that binds the minor groove of the DNA of cancer cells. The combination of chemo and immunotherapy, followed by immunotherapy and chemotherapy maintenance, is really considered the standard of care for extensive stage small cell lung cancer. There's been a number of really exciting agents if the disease was to come back, which we call relapsed disease, that has really blown this field wide open in the last few years with agents like T-cell engagers, antibody-drug conjugates, and some other drugs we're seeing coming down the pipeline.
Yeah, and I definitely want to get into that. My first research in my kind of advanced training and residency and in fellowship was in small cell because there wasn't a whole lot out there. And I felt that was where the greatest need was. And nowadays, I think there's a lot more hope. And Matt, I'm curious, when you were doing your Googling, did you get any evidence in there that, hey, there's actually some optimism here that maybe wasn't here 5 years ago?
No, absolutely not. Because you just, for one, you don't always know where to look. And I was even asked this question not too long ago. I feel like you get a lot of the information at the clinical level with your doctor. And like Misty was saying earlier, with the other groups and stuff, you find out information that normally you wouldn't have access to because like my medical oncologist doesn't know, or isn't, that's not where his focus is because he is treating everybody across the board. And at Google, yeah, absolutely. No, I was scared to death after Googling. And I was like, please hope nobody in my family Googles this. Because I didn't want them to worry even more. But yeah, so it really, for me, it took really attending my first lung cancer summit with a bunch of other people and professionals like yourself coming in and talking directly to me outside the clinic level, which made me actually instill some more hope for the future and actually be thankful that I wasn't diagnosed, 6 years ago when there wasn't a lot that I now know about now.
Matt, thanks for sharing that sliver of optimism here. And I think we want to maintain realistic outlooks for everything, but whenever there's reason to hold on to hope, we need that. That is really important for all of us, and there's no reason to not grab onto that as well as we can. What elements of maybe treatments that have come out now or treatments that are at the forefront have you heard about that gave you most excitement?
I don't know how to answer that question because I feel like I'm really new to this information.
Yeah.
And I'm still so very lost. Like today, I literally went into my oncologist office and said, well, what's the green light for the next treatment and what's the red light? And he gave me really, if there's still cancer, then it's a green light. If it's not, then you've done 5 rounds. And I said, well, what's next? Immunotherapy? And he said, no. And I said, well, I just learned about this last week, and I said, well, I'm going to pronounce this wrong, but the D word medicine. I said, what about that? And he's like, oh, that's for extensive stage only. And then he logged into his computer and pulled up a website and then went through the cycles of standard of treatment and said, oh, well, they have this one immunotherapy, but we don't want to give that to you yet because it could make your infection in your lung, if it is an infection, be worse. So I'm like, okay, like that. So that's where I'm at. So there's so much I still feel like I don't know. And I still feel like I'm still trying to find my guiding light in the dark by myself through this, which is just really honestly leaving me to go find other answers, other places, no matter what that distance takes me, to make sure that I've got the best information to be the advocate for myself and my treatment plan when I really, really do feel like I totally have no idea what's going on. So,
Yeah, and I think I even recommend my own patients get second opinions. Even though I only treat lung cancer, I think there's utility of seeing a different perspective. Even this stuff is nuanced. This stuff is complicated, and other institutions have resources and have trials and have things that may not be available where you're at. So I think your sentiment on the provider side, we can't echo stronger. That whatever makes you most comfortable in the treatment plan you're on is what you should be doing.
Yeah, like for example, they've talked to me about if everything goes well, then PCI as an option. I've had one doctor say yes, PCI, that's what we're doing, and then another one say they don't do that anymore, and then another one say, oh yeah, we could talk about it later. But then like if I get the cochlear implants and I don't choose to do it, then there's only so many testings of MRIs that have been tested on a cochlear, and what's that look like down the road. So I feel like I get so many different answers being bounced off of about that as well. I even asked the doctor just last week who totally sidestepped the question, and I totally seen her sidestep the question, but I still asked it, but I think she didn't know what to say. So she just kind of put it out there a different way that I totally read through it. But there's just so much information, and sometimes you just everybody has a different opinion. And it's like, I just want someone to say, hey, this is what we're doing. Because I do tend to trust my doctors. Yeah, I don't know what you guys went to school for. So if you tell me this is what we're going to do, I'm usually like, oh, yay, awesome. But for this, I'm like, just I'm just overwhelmed is probably the best word.
Well, I think you're hitting against something that's an evolving practice style right now. Um, and, it wasn't in the original plan to get into what PCI is, but I think there's probably a lot of people that may be in the cards for them. So for those listening, the hesitation you're hearing in my voice is that this is actually kind of a touchy subject in this disease type, in that some places will do it, some places will not do it. So there is practice style variation here. Misty, do you want to touch this hot fire or?
Oh, of course. So, prophylactic cranial radiation, or PCI, is this type of radiation that's to help potentially prevent areas that might occur in the brain called brain mets or brain metastases. And so PCI historically in the early 2000s was studied in both limited stage and extensive stage, so that patients, when they received chemotherapy, and had scans that showed that there was cancer that was responding, things were shrinking, they were stable, they were not spreading or growing, then patients were, recommended to get PCI or not. And they were evaluated for areas in the brain, time to failure, or areas in the brain, and then survival. And Dr. Slotman and this cooperative group came to the conclusion that patients had benefit and lived longer with PCI. Now, this was back in the days of CT scans and not brain MRIs. So we were lower resolution. It was not the 4K HD MRI scans that we're getting today, where we can see the slightest, tiniest change. And patients only got scans if they had symptoms. Not all patients had scans at the beginning. So how many patients had areas in the brain that they didn't know about, that we were missing because they weren't scanning and it wasn't the right type of scan? And so in 2017, there was a phase 3 study with Dr. Takahashi leading this effort in Japan. And that study showed in patients with extensive stage, they were randomized to either get PCI or brain MRIs every 3 months. And there was no difference in survival or outcomes. And so that really called into question, as a field, should we really be giving PCI to patients who have small cell lung cancer? There's a big study called Maverick that's investigating this right now. Hopefully we'll read out very soon and see those results. But to know in limited stage and extensive stage, should we be giving it? For my personal practice, I don't recommend it. I do discuss it with my patients. I have them discuss it with the radiation oncologist in a multidisciplinary effort. But I don't typically recommend it. And I think that's where the field is moving. But I agree, this is a very controversial topic. And the final word is still out with Maverick, if this is going to be implemented in our care or not.
Yeah, that very elegant way of explaining. And I love you're such a specialist in small cells, so I get to hear the historical arc to, your answers are far more elegant than mine are. I need to put your stuff on a note card for when I walk in with my individuals who have small cell. And because you tell a story and it's like, I want to sit and listen. Yeah, I would say my practice style is the same. I tend to not do PCI. It would be a rare patient who really, really wanted it. The conversation is still, I'm all about having the conversation. And if they want to chat with radiation oncology and, it's their care, they're the ones that have to suffer the consequences of any of the decisions that happen. So they should have the opportunity to do what they feel is best for them. But it's not something I routinely recommend. And the other thing to consider is, when we say prophylactic, we mean the scan doesn't have any disease there. This is thinking if something's seated in there and we can't see it, are we killing things that are too small to see on the scan? So it's a pretty aggressive treatment paradigm to do it. And maybe since we're on this road, Misty, could you speak to some of the side effects of PCI? Like, why not do it? Why not just radiate the brain?
So PCI does have real tangible side effects. First being fatigue that can occur even while you're doing the radiation or shortly thereafter. And you can have some neurologic changes, whether that be memory, right? Acute memory loss, distant memory loss, as well as unusual, neurologic side effects, just feeling very lethargic, feeling very tired, and taking a lot more effort, and as mentioned, our brain is essential. And so, radiation to critical structures, it can definitely be impactful for patients. We also see this with whole brain radiation, which is a higher dose treating the brain. And we see very similar side effects for patients, and they can be permanent or lifelong. And so I typically do follow something called the FIRE small cell study, which is using targeted radiation. If there's ever a spot that pops up in the brain, I'm arguing for my patient to get targeted radiation to avoid these side effects, because we want patients, as mentioned, to live as good of a quality of life for as long of life as possible. And that includes making sure we protect their brain.
Well, and I love what you mentioned, Matt, which is, well, first of all, Misty, again, with the historical precedents, thank you for including those. This is one of the nice things about being a podcast host, is you get to have the experts in their niche field, and then I get to steal all of your stuff for my own clinical practice.
Yeah.
So, and then I sound smarter, which is nice. But Matt, you were mentioning you're hearing in the periphery about all this hope that we feel, but it is really hard if you're searching for what should I expect. It may take a few layers of the onion to get down to the reasons why individuals like Misty and myself are really excited about the future of this field. And part of that is actually in the realm of how we deal with brain disease and how we treat that. Back a long time ago, we didn't have, well, not that long ago, a short time ago, we didn't really have a whole lot of things that worked that well in the brain. Misty, maybe you can speak a little bit to some recent advancements. Pick your poison. There's a few to choose from, which maybe are standard of care now and are now emerging to soon be standard of care, most likely, which we can anchor some hope onto, including in the realm of treating brain disease.
Absolutely. So in terms of areas in the brain, we've historically known that chemotherapy can impact areas in the brain. And so we always want to get a brain scan, a brain MRI at diagnosis, and getting patients plugged into our radiation oncologists. But, it is fair to closely watch these areas. If there's spots, patients are not symptomatic, there's no swelling, it's reasonable to try our chemotherapies and immunotherapies, because those both do have an ability to cross into the brain and impact these areas of the brain and keep them stable or shrink them. But it's important as we come into these new therapies, drugs like tarlatamab, which is a DLL3, CD3 bispecific T-cell engager, we call that a BiTE, that is a super glue that's going to glue your small cell and your T cell together. That has it's impactful to help patients, a subset of patients, to help control the disease in about 70% of patients who are diagnosed with small cell, shrinkage in about 40% of patients, and durability, majority of patients having shrinkage that's lasting over 6 months, really over a year, years, I think more to come. But what we know about this bispecific T-cell engager that targets DLL3 is that it has activity in the brain. We've seen a few case series, as well as the original trials showing that there's activity in the brain. So maybe these are patients, we can avoid whole brain radiation. We can avoid radiation altogether. If it's going to shrink in the body, it will likely shrink in the brain. So this is really important. Of course, we still have to do all of our imaging, making sure that we're monitoring closely and always imaging for any new symptoms. We know that another drug, lurbinectedin, which is a minor groove binder, an alkylating agent, that is effective in small cell, is too large. It's derived from the C-squirt, and it's a too large semi-synthetic molecule to get across the blood-brain barrier. And so that is not a drug that I typically will pull for if I know patients have a history of areas in the brain. We also have seen these antibody-drug conjugates, or ADCs, several of them targeting B7H3, SEZ6, TROP2, and DLL3, and more to come. They're really exciting, high response rate, high disease control rate, sometimes upwards of 95%, keeping the disease stable, shrinking, or completely gone. And they have activity in the brain as well. And so these are really exciting, kind of a chemotherapy with attached to an antibody, like a Trojan horse being ushered into the cancer cell and killing the cell and the surrounding cells with this bystander effect. It's also effective in the brain. And so is radiation, and specifically this whole brain generalized radiation, a thing of the past? I think we're getting there, and we will soon, not do that for our patients with small cell.
Yeah, and thanks for explaining. And this whole multiple classes of therapies, right now, most of that is really being tried in the extensive stage once the disease is spread around. But there are trials evaluating these types of things in the limited stage too. So I'm eager to hear how they advance our care. But these have been really exciting for us.
Yeah.
I mean, what was I don't want to, I guess, put phrasing in your mouth, but we haven't had great, exciting trials in small cell for a while. Even the immunotherapy only improved the median overall survival by, roughly how much, Misty?
Yeah, 2 to 3 months. 2 to 3 months.
And that was standard of care immediately. It was the biggest excitement in the field that had happened in decades.
Yeah.
And how would you, I guess, grade our level of excitement around these things?
These are transformative. These, we saw the data from one of the recent phase 1b studies, Delphi 303, which is using tarlatamab in the maintenance setting. So after chemoimmunotherapy, getting immunotherapy and tarlatamab, this bispecific T-cell engager, we saw a doubling of overall survival in that study. Now, phase 3 is ongoing. Hopefully we'll see that soon. And if that's going to come into practice, maybe these are going to come into the front line or at first diagnosis or limited stage. I think we're trying to figure out where these drugs will land, but we're truly changing and transforming the biology of small cell to a new landscape where patients are living longer. They're being, put in remission, and dare I say it, I think being cured.
Yeah, it's hard. I think in both of our trainings, cure was very, very much a 4-letter word, and we were really hesitant to use that term in anyone who had advanced disease. But for many of these therapies that have immunologic components to them, we've seen these long-term responses that really look like they really might be.
Yeah.
And, as a researcher, how has that hope inspired you in the laboratory, given you, I guess, the fuel to keep pushing through in what is really a really hard field to study?
Yeah, I think that these voices of hope and these needles in the haystack are going to be more and more common. And I think this is where biomarkers are absolutely key to figure out what's the right treatment for what patient. In our laboratory, we study lurbinectedin, and we have a biomarker because of these. We had these subset of patients who had fantastic responses with extensive stage. I personally have a patient right now who's about to get cycle 50 of lurbinectedin and has no evidence of cancer and is living her best life. And so, these are patients that we want to find and get them the right therapy. And so, how do we do that? And biomarkers here are key. Study the patients who do really well and maybe those who don't, and what's different or unique about those patients. And so that's what we did. And that landed us on a biomarker called ISL1, which is really the new neuroendocrine subtype for lurbinectedin specifically that we are studying and hoping to get into the clinics sometime in the near future.
Yeah, I absolutely. Really inspiring work too. The other types of lung cancer, we've had these really different slivers of the pie where if they have this, you do this. If they have that, you do that. And we saw really outstanding responses if you're able to match the tumor to the right treatment in a really well thought out way because of our understanding of the biology. And small cell hadn't for a long time followed that paradigm, and it was really hard. So, Misty, I can say from my background knowledge, what you do is really, really hard. And to push through the level of difficulty it is and the number of failed experiments one has to do before you find something that works. And there's no guarantee that what you're trying is going to work. I really appreciate all you do in the lab. And I think, not only is it brilliant work, but it's patient-centered, and this is the kind of thing we need to transform the field. So I value everything you do in the lab and everything you're doing with the smashers. And also your signature handle has a little image of a shield matching your last name. And I thought that was really clever. I'm Irish descent, and we all have our little insignias and stuff. So it's like, oh man, I never thought about doing that, but
you'll need one.
Yeah, I don't know. I don't even know what Concannon little emblem of me and like artillery. I don't know.
There we go.
Yeah, we got to figure something out. But I think, we've covered a lot of ground today, and Matt, what elements, what questions do you have that you think we haven't answered for someone who's newly diagnosed?
I think we pretty much have a nice broad spectrum that we talked about today. I think one of the things that I just really want to express to anybody is just I know that there's moments where I really feel like I'm on that solo path trying to figure this out, but there are those little resources that have made a difference in a very small amount of time. I like to use this reference a lot. At one point in my college career, I said, I'm going to be a photographer. And I took like 4 semesters of photography classes, but it was at an art school. It was horrible. And I learned more in one workshop with a photographer in the field than I did in 4 semesters in the classroom. And I kind of take that approach to this. I learned more in one summit than I did in every visit with my doctor. Not only from professionals in the field, but sitting around a table talking to other people that have been on this path somewhat like me. And that has really made a difference and made me feel like, okay, this is what I have to do. Or like, I don't want to hurt my oncologist's feelings if I don't go back to him again. Like, he doesn't care at the end of the day. But I shouldn't care either if I'm really not feeling like I'm getting my needs met. Just really, and like I always say, every victory does not have to be fireworks. It doesn't have to be a huge, like a parade with bands walking down the street. If your victory for the day is literally making it to the fridge and pouring yourself a glass of water, all those small accomplishments add up to get you through the day and to increase that hope for the future.
Wow. Well said. Thank you for sharing that. And Misty, any last piece of advice or parting wisdoms for listeners here?
Thanks, Kyle. And, I think this was a lovely discussion, and I've certainly learned a lot. And I think that, for our listeners or our loved ones, just know you're not alone. You're not going through this alone. You've got people all over the world who see you, who are fighting for you, fighting with you. We're just one, message, phone call, just one reach away, however we can help. You're not in this alone. You've got a team, your medical team, your family, your loved ones, your friends, our fellow smashers and other support groups all here fighting for you. If your needs aren't being met, tell your team, there's resources that are available to help you all over the world and to try to sort this out together. Again, you're not alone. Never give up hope, and just take it one step at a time.
Well, nothing to add. Thank you for relaying that and all the work you've both done. All right. Well, I think that's as good a place to cut it as any. Matt and Misty, thank you both so much for joining today.
Thank you for having us.
Thank you.
No, my pleasure. And everyone else who's listening, you can find this at crackingcancer.org and all available podcast sites. All right. Thanks, everyone. Thank you for joining us on this episode of Cracking Cancer. If you found this helpful, please like, subscribe, leave us a review, and visit crackingcancer.org for more information. Every dollar we earn goes directly to furthering the podcast and supporting vital cancer research, because together we can crack cancer.